So, I mean, ultimately, the theory here is, well, everything's kind of better if you design it best in the first place. And certainly those elements of, how do you get enough humanization in a monoclonal antibody with the same things we've just heard talk about, right? Retaining potency, reducing T cell epitopes, and then also maybe a bit more difficult to predict, but reducing B cell epitopes as well. So just to dive a bit into the assays, and say this one here, we actually used ProImmune's ProMap T cell proliferation assay. So as I say, we did screen out risk, or we looked to screen out risk by the in silico, and then we take the peptides that we've either not screened out or ones we want to check whether they are actually nice and clean, put those into the PBMC assay and look for T cell proliferation. You can kind of see on the right-hand side, there's a couple of examples. One where we had a parental sequence that was, remarkably antigenic in the assay, possibly one of the strongest responses we've had in this assay. And then by in silico design, having gone through and selected a few potential alternatives and demonstrating this range of different outcomes in that PBMC assay. And so with the, I think it was like a 10-week turnaround from ProImmune, we were able to get this data back about the same time we'd got data back on potency assays and some of the other assays the protein engineering group were doing. So this kind of helped us to say, well, yeah, look, these are good options, and they were also good options as far as the project was concerned. On a slightly different note, and probably almost always what we'd like to see, is one project that followed both the ABS approach and sort of some kind of intensity on the in silico. We were able to pick out all of these, both framework regions and CDR regions, and putting those into the ProMap assay. We got nothing more than, I think one of the framework here had 2 donor responses, so 2 out of 40 was a 5%. And so we kind of highlighted all this as low risk. ProMap helping us identify a low immunogenicity clinical molecule, I think is a good advert. So in the spirit of kind of looking at what we were doing for boxizumab from a retrospective, and I think this talks a bit again to the deimmunization question. We can kind of look back and go, well, if you look at in silico prediction, if you look at running peptide assays, that there are quite a few potential liabilities. And just to kind of highlight some of the sequences we looked at, there was one particular one in the CDRL2 that gave a fairly strong response. And I think these X's are essentially lined up. So you can see as we walked across it that sort of disappeared. So, we'd highlighted here that there was certainly a liability. At the time, we weren't actually able to find that sequence with a MAPS analysis presented, but we've kind of been doing further work on that, and again that may be subject to disclosure at a later date. So take-home messages: immunogenicity is a significant barrier to drug development, but the current predictions are actionable. So we can do that both in the molecular design stage and then impacting or looking at the impact in clinical trials. I mean, the simple thing, I guess, like we just heard, remove the T cell epitopes to avoid immunogenicity is a really good starting place, because we have lots of great tools to do that. And I think I'm going to hear more from Jeremy on that very shortly.